Hey everyone, and welcome back to the channel. Today, we're diving deep into the world of biliary tract diseases. If you're a medical student, you know these terms can get super confusing. Cholecystitis, Cholelithiasis, Cholangitis, and Choledocholithiasis. They all sound similar, but they describe very different, though often related, conditions. Our goal today is to untangle these four core conditions so you can confidently differentiate them for your exams and clinical practice. We'll break down the pathophysiology, clinical presentation, diagnosis, and management for each one. So grab your notebooks, and let's get started. First up, let's talk about the foundation of most of these problems. Cholelithiasis. The suffix lithiasis means the presence of stones. So, cholelithiasis simply means gallstones in the gallbladder. It's incredibly common, affecting millions of people. These stones are usually made of cholesterol or biliary. Now, the key thing to remember is that most people with gallstones are asymptomatic. The stones just hang out in the gallbladder, not causing any trouble. We often find them incidentally on an ultrasound done for another reason. For these asymptomatic cases, we generally don't do anything. The approach is watchful waiting. This isn't a disease itself, but a symptom. Imagine a gallstone temporarily blocking the cystic ductal tube that drains the gallbladder. When you eat a fatty meal, your gallbladder contracts to release bile, but it's pushing against this blockage. This causes a sudden, intense pain in the right upper quadrant or epigastric area, which can radiate to the right shoulder or back. Lab tests, like liver function tests and a white blood cell count, are typically normal. An ultrasound will show the gallstones, but no signs of inflammation. The treatment here is elective cholecystectomy, removing the gallbladder to prevent future episodes and more serious complications. This brings us to our first major itis, cholecystitis. The suffix itis means inflammation. So, cholecystitis is inflammation of the gallbladder. This happens when a gallstone gets stuck in the cystic duct and doesn't dislodge. The blockage is persistent. The trapped bile irritates the gallbladder wall, leading to inflammation, swelling, and potentially infection. Patients often have a fever, nausea, and vomiting. On physical exam, you'll find a positive Murphy's sign. When you press on the right upper quadrant and ask the patient to breathe in, they'll stop abruptly due to the pain as the inflamed gallbladder hits your hand. For diagnosis, an ultrasound is the first-line imaging test. You'll see gallstones, a thickened gallbladder wall, and fluid around the gallbladder, which are all signs of inflammation. If the ultrasound is inconclusive, a HEDA scan is the most specific test. A HEDA scan uses a radioactive tracer to watch the bile flow. In cholecystitis, the tracer will fill the liver and common bile duct, but it won't enter the gallbladder because the cystic duct is blocked. Lab work will often show an elevated white blood cell count, or leukocyte-filled liver enzymes might be slightly elevated, but not significantly. The definitive treatment is cholecystectomy, ideally within 24 to 72 hours of admission. Now, let's shift our focus from the gallbladder to the bile ducts. This is where Choledocholithiasis comes in. Choledocho refers to the common bile duct, and lithiasis again means stone. So, Choledocholithiasis is a gallstone in the common bile duct. A stone in the common bile duct can obstruct the flow of bile from the liver to the small intestine. Clinical presentation can vary. Sometimes it's asymptomatic, other times it presents with right upper quadrant pain, but the classic signs are related to the bile backup. This backup causes jaundice siloing of the skin and eyes because bilirubin can't be excreted properly. Lab tests are key here. You'll see a cholestatic pattern of liver injury, meaning a significant elevation in alkaline phosphatase, ALK. An ultrasound might show a dilated common bile duct, and sometimes you can even see the stone. However, the best diagnostic and therapeutic procedure is an ERCP endoscopic retrograde cholangitis. During an ERCP, an endoscope is passed down to the duodenum. A catheter is inserted into the common bile duct, and the stone can be visualized and removed. Now for our final and most dangerous condition, cholangitis. This is an infection of the biliary tree, almost always caused by an obstruction. The most common cause of that obstruction is, you guessed it, Choledocholithiasis. When bile flow is blocked, the static bile is a perfect breeding ground for bacteria, leading to a nasty infection. This is a medical emergency. Patients with acute cholangitis are very sick. They classically present with Charcot's triad, right upper quadrant pain, fever, and jaundice. It's crucial to recognize this triad. Jewel. See the lab findings of Choledocholithiasis high bilirubin and ALK Phos plus signs of severe infection, like a very high white blood cell count and positive blood cultures. The management of cholangitis is urgent. First, you need to stabilize the patient with IV fluids and broad-spectrum IV antibiotics. The procedure of choice for biliary decompression is ERCP. Just like with Choledocholithiasis, ERCP allows for both diagnosis and treatment by removing the obstructing stone and draining the infected bile. After the acute infection resolves, the patient will usually undergo a cholecystectomy to remove the source of the stones. Cholelithiasis is just stones in the gallbladder, often asymptomatic. If that stone gets stuck and causes inflammation, it's cholecystitis, constant pain, fever, and a positive Murphy's sign. If a stone moves into the common bile duct, it's choledocholithiasis, leading to jaundice and elevated ALK Phos. And finally, if that obstructed duct gets infected, it becomes cholangitis, a life-threatening emergency presenting with Charcot's triad of pain, fever, and jaundice. B. Understanding the location of the stone and whether there's inflammation or infection is the key to differentiating these four conditions. I hope this breakdown makes these confusing topics much clearer for you. Differentiating them really comes down to a few key features in the history, physical exam, and lab work. Keep practicing questions and reviewing these concepts, and you'll master them in no time. P.O. If you found this video helpful, please give it a thumbs up, and don't forget to subscribe for more content to help you ace your exams. Let me know in the comments if there are other topics you'd like me to cover. Thanks for watching, and I'll see you in the next video.